Infective endocarditis is a serious infection that affects the endocardium, which is the inner lining of the heart chambers and heart valves. This condition occurs when pathogens enter the bloodstream and attach to the areas of heart, leading to infection and inflammation. Infective endocarditis can damage heart valves, cause the formation of blood clots, and potentially lead to life-threatening complications. Symptoms of infective endocarditis can vary, but when someone has fever along with the new onset of cardiac murmur, it is considered as infective endocarditis until proven otherwise. There may also be a complaint of fatigue, muscle pain, and joint pain. Patient may experience night sweats, chills, and unexplained weight loss. Risk factors are pre-existing heart valve disease, congenital heart defects, history of infective endocarditis, intravenous drug use, some medical procedures that may introduce bacteria into the bloodstream. Infective endocarditis is caused by bacteria such as Staphylococcus aureus is the commonest cause of infective endocarditis. Staph epidermidis is the commonest cause after prostatic valve surgery. Staph viridans are the commonest cause in people with poor dental hygiene or following a dental procedure. In IV drug users, infective endocarditis is frequently caused by Staphylococcus aureus infection, with higher prevalence of tricuspid valve involvement, leading to hollow systolic murmur and common occurrence of septic pulmonary emboli. The diagnosis of infective endocarditis involves a combination of clinical evaluation and diagnostic workup. Modified Duke criteria serve as diagnostic guidelines for identifying infective endocarditis and can be met through a combination of criteria: two major criteria, or one major plus three minor criteria, or five minor criteria. Major criteria to evaluate the existence of positive blood cultures and signs of irregularities in the heart valves include positive blood cultures, and there are three options: either two positive blood cultures with typical organisms like Streptococcus viridans, or alternatively, persistent bacteremia confirmed by two blood cultures taking at least 12 hours apart, or three or more positive blood cultures with less specific pathogens like Staph aureus and Staph epidermidis. Second option is evidence of endocardial involvement. A positive echocardiogram can reveal oscillating structures, abscess formation, or issue with prostatic valves, and it can also detect new valvular regurgitation. Minor criteria include pre-existing heart conditions or intravenous drug use, microbiological evidence that does not meet the major criteria, fever more than 38 degrees Celsius, vascular phenomena which is emboli, splenomegaly, clubbing purpura, splinter hemorrhage, Janvial lesions which are non-tender small erythematous, hemorrhagic macules, or nodular lesion on the soles or palms. Immunological phenomena which is glomerulonephritis, ocular nodules which are painful red nodules on the hands or feet that can persist for hours to days, rot spots. Treatment of infective endocarditis requires hospitalization and intravenous antibiotics, usually non-urgent, and can wait for confirmation of etiology before initiating treatment. Emphatic antibiotic therapy, if patient is unstable, administer only after blood cultures have been taken. First-line treatment for native valve involvement is vancomycin with gentamicin or ceftriaxone. For prostatic valve involvement, vancomycin with gentamicin, cefepime, and rifampin. Duration of antibiotic therapy is 4 to 6 weeks, adjusted based on valve organism and sensitivity. In severe cases or when complications like valve damage occurs, surgical intervention may be necessary to repair or replace damaged heart valves. Prophylaxis only for high-risk individuals such as dental procedures that may lead to bleeding, invasive procedures of respiratory tract that involves incision or biopsy of the respiratory mucosa such as tonsillectomy, procedures on infected skin, skin structures, or musculoskeletal tissues. For dental and respiratory procedures, the prophylaxis is amoxicillin. For soft tissues and skin procedures, the prophylaxis antibiotic is cephalhexin. The prognosis for individuals with infective endocarditis depends on the various factors, including the causative microorganism, the extent of heart valve damage, and how quickly the infection is diagnosed and treated. Early diagnosis and appropriate treatment are essential to improve outcome. Thanks for watching. Do not forget to like and subscribe.